goes into essentially just those, the complications of pregnancy and in the postpartum time frame that just really didn't fit anywhere else. So the first thing that we're going to talk about is preterm labor. So what is preterm again? It's going to be anything less than 37 weeks of delivery. So your 36 and 6 babies are still going to be considered preterm. So some characteristics of a preterm delivery is basically anything in which we have contractions with active cervical changes. If risks we're looking at, if we have if we're African American Black, if we have a history of preterm labors, hypertension or preeclampsia, that's all fine and good, but again, 50% of these women will not carry any risk factors. Again, if at all possible, if we're able to look at those women who are at higher risk, we're going to do a vaginal ultrasound to measure that cervix, make sure that we don't have that incompetent cervix that we talked about earlier. We're going to draw a CBC to make sure that we don't have a ton of infection going on. And then women with a history of UTIs are also at risk of preterm labor. Often, sometimes that is the only thing that they have going on. Again, if we're at high risk for preterm labor, if we have a history of that, or perhaps we've got some hypertension or diabetes on board, we might do a test called febrile fibronectin. So what we're looking at here are the glycoproteins that are found in plasma produced during fetal life. And these, if you're looking here, you can see where the amniotic sac is coming right up against the maternal membranes of the uterus, and we've got this fetal fibronectin, and it's holding it in place, okay? When you have that bag of water, so you think about, it's not really swooshing around all the time, right? It's kind of held in place. So if we start to see this begin to detach, we're able to detect this in a swab of cervical secretions. So we normally find it in the beginning and at the end of pregnancy, but if we're finding it late in the second trimester, early in the third trimester, then it can indicate placental inflammation. So again, if we have anybody who is at high risk, then we're going to swab them just to see where they're at. Some symptoms of preterm labor: low, dull backache, change or increase in vaginal discharge. Again, these are literally signs of labor, but some women don't necessarily recognize that they're in labor because it's not mimicking per se or it's it's too early. It's not on their radar. They just think it's they did too much the previous day or what have you. Treatment, we're going to put them on bed rest. We're going to put them onto their side. We're going to give them IV fluids. If they're anything greater than 4, we're going to likely allow for progression of labor. If they're anything less than that, we're going to try to stop it. We're going to assess for amniotic fluid leakage. Are we leaking? Have our bag of waters ruptured? Can we maybe give some tocolytics if our uterus is starting to go kind of wonky, and we need to try to slow things down? This is not the time to be giving that Pitocin, right? We can do some home uterine monitoring. It's high cost. It's going to require a phone modem, which a lot of people don't have. So it's not something that's really realistic for a lot of, at least our patient population. Some of the medications that we're going to give, beta mimetics, include terbutaline, which remember we talked about in the past. This one is typically used for asthmatics. It relaxes smooth muscle, which includes uterine muscle. It can cause some feelings of arrhythmia, headaches, tachycardia, and arrhythmia in the fetus as well. And then procardia. This, we typically use as the calcium channel blocker. So we're preventing calcium from entering that smooth muscle, which then inhibits uterine contractions. We're not able to have that muscle function. Not a ton of fetal side effects. MAG. This is probably the one that I see the most. The mechanism of action is unknown in preterm labor. It inhibits neurotransmission. This, I have heard, makes people feel awful, but it does the job. Indomethacin blocks the action of prostaglandins. It can have some referred side effects to the fetus. It's contraindicated in people with hypertension. Well, why? Okay, indomethacin can cause, as a side effect, some elevated blood pressures. If we already have hypertension, we're not going to give you a medication that fully, then increases your blood pressure even higher. Should also not be given to asthmatics. Antenatal corticosteroids. So this is a non-tocolytic medication. Antenatal corticosteroids. So we're going to give beta or betamethasone to a mom that is showing either it's at high risk for preterm labor, or has shown signs of preterm labor starting. With this, what we're trying to do is we give it to mom as an IM injection, but it's really to help baby do that transition process. Usually, remember, we don't have that fetal lung maturity until later on in the 3rd trimester. We don't have that surfactant production until later on. However, betamethasone, if we have a chance to give it, we can do that, and it helps promote the release of surfactant-producing enzymes. So let's get the enzymes going. Let's get that surfactant on board. We're trying to help our baby here, okay? It also helps to decrease the rate of intraventricular hemorrhage. We can give this once a week, okay? We give it 2 doses, 12 hours apart. And then if we are able to stabilize the preterm labor, if we're able to stop the labor from progressing, the woman does all the things that she's supposed to do, we are able to repeat this beta several times after. And this can be given also in the office in addition to the hospital. So a lot of times you might hear in your NICU report that mom had beta times 1, mom had beta times 3. You don't usually hear beta times 4, but I have heard beta up to 3. Post-term pregnancy is after 42 weeks. Hey, I'm a 42-week gestation baby, okay? So I've always said I was late at delivery, and I've been late ever since, and that's just the way that we go. So potential complications, again, dystocia. Are we allowing this baby to get too large? Even though, remember when we talked about shoulder dystocia, that it can happen at any rate, at any age, at any weight, at any size. But still, they say, you can end up with a large baby, and it can it end up with a shoulder dystocia? Well, put that on everybody's, but okay, whatever. Birth trauma, again, is this baby too large? Fetal implications. So the placenta starts to age out and becomes calcified. It's got like a short lifespan. Its lifespan is at the max like 42 weeks. And as it becomes less efficient, as it just ages out, it's not going to perfuse the way that it should. That concerns us for, obviously, nutrient and oxygen delivery to our fetus, but then as well, what is that placenta going to do during the delivery process? So, because we're concerned about whether or not that placenta is going to be able to fully function and get our baby what it needs to during the actual delivery process, when things are constricted and, we have that perfusion and whatnot, we're going through that normal process, we're going to do non-stress tests, biophysical profiles, etc. Okay, preterm rupture of membranes. So preterm rupture of membranes is a rupture or a leak, okay, at least 1 hour before the onset of true labor, before we're starting to see those cervical changes. This is the highest risk for infection, and after, if we're ruptured for more than 24 hours, we see a higher incidence of chorioamnitis or chorio. In this case, what happens, as you can see, the bacteria in this diagram come through the cervix, or come through the vaginal canal up through the cervix, and because our bag of waters is ruptured, we have no defense. If our bag of waters is ruptured, then our mucus plug is gone. And we're able, that bacteria is able to ascend up in here and able to infect our cute little baby. The amniotic chorion is what is the space between the amniotic sac and the chorion of the mom. We can end up with endometritis, we can end up with neonatal sepsis, and we don't have a ton of fetal membrane strength. So risk factors include group beta strep. So group beta strep, remember, it's a vaginal flora that can be found in up to 50% of women. Doesn't mean anything in particular, and we're not really ever concerned about it unless we have this case. Chlamydia, gonorrhea, bacterial vaginosis. So if we have some other infections that are actively going on at the time, that can also put the mom at risk or the baby at risk for chorioamnitis. But premature rupture of membranes can also be a factor with that. Like, it can also cause that premature rupture of membranes because everything is just so irritable. You've got an active infection going on and everything's inflamed. Uterus becomes irritable. So then you can also have PPROM. So preterm premature rupture of the membranes. So this is when our bag of waters breaks before 37 weeks. We have that super high risk of infection. Obviously, we're concerned for a premature delivery. With this management, if we have a slow trickle of amniotic fluid, we hope, we pray, we give the beta, we put that mom on her side, we try to do some tocolytics, amniotic fluid continues to be produced, and maybe that amniotic sac, if it's a slow leak, will heal itself. Maybe. Okay. Otherwise, we're going to do biophysical profiles. We're going to do kit counts. We're going to keep a close eye on this baby. Amnio infusion, I asked up at our labor unit on Swedes. They say they do a couple of them a year. So again, this is warm, sterile water that is actually infused into the uterus when we had this preterm premature rupture of membranes, and we're trying to get this baby a little bit further on in the delivery for, it's better health for the baby, right? Better outcome for baby, better outcome for mom. So you might see this amnio infusion take place a few times, and if you're lucky, during your observation time. Some other complications of pregnancy include our multiple gestation. So we have our monozygotic and our dizygotic twins. So mono, di. We talk about that happening as well. How do we know that we have twins? Well, we do an ultrasound. We also might have some other potential complications, IUGR, so intrauterine growth restriction. We have a fetus eventually that is smaller than expected for gestational age at some point or whatever. The body just says, you know what, I'm sick of feeding you and I am tired of you being such a strain on my life and I'm no longer going to give you anything. So the mother's body might happen to have that with this baby. Prematurity can cause, we can see prematurity with these babies. Mother's body can no longer handle it and we go into preterm labor. Some other potential risks include conjoined twins, and this mom is going to perhaps have some increased pregnancy symptoms. Elevated HCG, which relates to perhaps some increased nausea and vomiting, constipation, pelvic pressure, anemia. Why anemia? Well, it's because she's got more than one bloodthirsty, leech attached to her. 20% of all pregnant women become iron deficient. We know that iron assists with transportation of oxygen, carbon dioxide. That's why it's so important. We're going to correct that deficiency. Remember, you're going to always give your iron with orange juice or with a citric acid and not with milk. Amniotic fluid emboli. I've mentioned this a few times, but we haven't really gone over it specifically. This occurs during delivery or immediately after delivery as the amniotic fluid is introduced into the maternal circulation. Unfortunately, when you think about everything that's floating around in the amniotic fluid, that embolus may contain meconium, lanugo, vernix, etc. Enter enters into the maternal pulmonary system, you guys, this is just not a good situation. If we end up with an amniotic fluid emboli, these moms are going to go suddenly hypoxic. They're suddenly going to go into hypotension. Why? Why is all that happening? We have a pulmonary and a cardiovascular system that is completely collapsing. CPR, calling a code. We've already talked about polyhydramnios. Potential causes of polyhydramnios include poor presentation, umbilical cord prolapse, and a fetal anomaly. Okay, so here we need to talk about this. Polyhydramnios can be related to esophageal atresia. Yes, it is true. When a baby is in the amniotic sac, they are swallowing the amniotic fluid and then they are peeing it out. Swallowing and peeing, swallowing and peeing. It is filtered, but the truth of the matter is that they're swimming along, around in their own pee. Well, if we have polyhydramnios, one of the things that we're going to be concerned for is esophageal atresia, in which the esophagus does not connect with the stomach. And you'll be talking more about this in your pediatric rotation with Professor McClelland. But the baby doesn't swallow amniotic fluid, but yet amniotic fluid continues to be made, so we might see polyhydramnios with this. In contrast, when we're looking at oligohydramnios, we're concerned that perhaps it's a renal anomaly, as in this baby is not peeing things out. Either way, we're going to be looking at a biophysical profile to help us identify whether, our amniotic fluid is too high, too low, or just right. Either way, we're going to monitor for blood pressure. In both cases, we're also going to monitor fetal well-being. In oligohydramnios, we're very concerned about cord compression as this baby comes through the umbilical, or, I shouldn't even say that, goes through the laboring process, and we have, that contraction of the uterus. There's not as much of that fluid, there's not as much of that give, there's not as much as that bounce, and so that cord can become compressed more frequently for longer periods of time. And this is, we're going to be monitoring that for variable decelerations. And this as well as another case where we might do an amnio infusion. And that concludes the random ones.